Thank you everyone for coming and joining us today. Welcome to the ICD-10 Code for Leukodystrophies webinar. We have Dr. Joshua Bonkowsky with University of Utah Health on the line, and we also have Garnette McLaughlin. She is with Intermountain Health, and she is our coding specialist and coding analyst, and with a particular affinity for appeals and denials as well. So they are going to present some information for you to explain what is this ICD-10 code, what do these things mean, what does it mean for me, what does it mean for my person, how can we utilize these codes to our advantage for the best possible outcomes for our people and persons that are affected by leukodystrophies. Just a reminder, this session is being recorded. It will be posted to YouTube, so if you have any privacy concerns, please be attentive to that to your own level of comfortability. Once Dr. Bonkowsky and Garnette have given their presentations, I will pop back up to say hello and help MC the Q&A session at the end. Thank you so much again for everyone joining us. And without further ado, Dr. Bonkowsky, take it away.
Thanks, Keely. Welcome everybody. So just to give a brief rundown of our session today, I'll give a brief, probably about 10 to 15 minutes introduction about what the codes are and kind of how we went about the process of developing them. And then Garnette will talk a little bit more about how codes are actually used in the medical system and kind of some of the nuts and bolts there. And then after our two presentations, if you could please hold your questions until after we finish speaking. Hopefully we'll answer some of your questions as we're talking, but then afterwards we're going to try and leave 20 or more minutes, maybe even up to 30 minutes for questions. Again, with your questions, please realize these codes are brand new. We've all been very excited to see them coming, but as we roll them out in the real world, there's still kind of a few steps of how things work, and so we don't want to over-promise what we can't over-deliver here. So please bear with us as we explain what the codes are and how to use them, but realize things are still rolling out. So I'm going to talk a little about the process of code development. A lot of the work was done by Monica Baker, a graduate student in our research group. She does have a major assignment test due this Friday, so I hopefully she can make it, but if she can't, speaking on her behalf as well.
She is on.
Oh, hi Monica. So so we're all here and we're familiar with the concept of a leukodystrophy, so a genetic disease affecting the white matter in the brain. They've been known for a long time, since the 1800s, but really the past 15 or so years there's been an explosion of understanding as we've used MRI to look at the people's brains, and then with genetic testing, we're realizing more and more how many different leukodystrophies there are. And so it's called a leukodystrophy because if you look at the brain, the part of the brain that's affected is the white matter, and it looks white. The word for white in Greek is leuko. So these are a very complex and diverse group of diseases. As we've learned more and more, we've realized there's more and more different genes that can be affected. There's, at this point, more than 400 different genes that can cause changes on MRI that look like a leukodystrophy. Each of these diseases has kind of a distinct pathway for what happens in the disease, so how people are affected, what kind of symptoms they have, what kind of treatments might or might not work. And in general, these are pretty rare conditions, or what we call orphan conditions, where there isn't as much known or as much treatment going on, and that's really been kind of a limiting factor. Unfortunately, these diseases tend to be pretty severe with a fairly high risk of death. So in the first decade of life, in general, there's almost a 30% risk of death. So pretty severe diseases. So at this point now, we've really realized that these are much more common as a group than we had initially thought. They affect close to 1 in 4,000 births if you put them all together. That's almost as common as cystic fibrosis in the Caucasian population. Though if you look at each individual leukodystrophy, it's much less common. So for example, X-linked adrenoleukodystrophy, which is probably one of the most common of the leukodystrophies, is 1 in 15,000 live births. So as a way to think about this, I work in Utah at Primary Children's Hospital, and with ALD, one of the more common ones, we're seeing about 4 or 5 new babies a year with ALD, and that's because the birth rate in Utah is about 50,000 births a year. Leukodystrophies are not unique to any one type of race or ethnicity or age. They affect all kinds of ages, ranging from newborn babies up to people in mid to late adulthood. It doesn't matter whether you're Black or white, if you come from a Ashkenazi Jewish heritage or other population, if you're Chinese American, leukodystrophies are across all populations. So the point of this was to talk about the ICD codes. So ICD codes obviously are what we use to assign a diagnosis to someone in clinical medicine. They are a way to give a machine-readable representation of a diagnosis. So it's what we call structured data. The data, once you put a code on it, you don't have to use complex algorithms. Not only is it used clinically, but we also use it now in research, because with large numbers of people, we can look into these large data sets to understand what's going on. As time has passed, ICD codes have become more and more specific, and we've used them really now over the past 10 years to understand different leukodystrophies. We can understand how common they are, how many times they occur at birth, what the costs are. If you can look at a large data set, how much it costs to have a leukodystrophy, how many times you get hospitalized, what happens between birth and 10 years of life. So very useful both for clinical care of patients, but also for understanding research. And the research is important because it helps us know what to recommend to families. So the problem is that until about 10 or 15 years ago, as we were mentioning, we only knew about a few leukodystrophies, and those ones had their own ICD-10 code. There are about 6 codes for leukodystrophies at the time. But now, as we were mentioning, there's more than 400 different leukodystrophies, each of them very unique. We actually have treatments that are available for different leukodystrophies, so it's important to have codes for those. There's clinical trials in process for other leukodystrophies. And then really research and clinical trials is driven in part by our understanding of data. And so these are, real impacts on families, on you guys, and it's, hundreds of millions of dollars of impact each year for people with leukodystrophies. And so having a specific code really lets you look at what's going on. So without a specific code, there's no way to look into a medical system and understand how many people have this disorder. We can't track what's happening over time or through a healthcare system or for a patient with a disease. We can't understand, how the care at one center is compared to a different center. It's hard to get ready for clinical trials. So even if there's a clinical trial, if you can't collect the data, you can't understand what your comparison group is going to be. And then sometimes people are assigned the wrong code. So for example, up until this month, I guess, right, there hasn't been a code for vanishing white matter disease. And so patients would sometimes be assigned a code for metachromatic leukodystrophy, even though this was, a totally different disease. So up until October, there were only codes for 6 different leukodystrophies. And those codes were super useful for helping us understand disease. And we've used them to understand how common ALD is, or to understand why people who lived closer to a major city got diagnosed more often than if you lived out in a rural area. Most of the other codes were all put into a single kind of bucket code, and meant that you couldn't really look into that bucket and understand what was going on. So this was something I had, and many of us have been complaining about for a while. And as it turns out, Monica Baker was really important for saying, Josh, there's actually a process for getting new ICD codes. And with Monica's help, it turns out that it's a complex process, but there's actually a pathway for how to do this. So back a couple of years ago now, we put together a proposal for 33 different leukodystrophies, which have been 46 different codes. We asked for the most common leukodystrophies, and also ones where we could see that there's either clinical trials in process or clinical trials coming. So we're asking for a lot of codes. So basically the process consists of, you develop these codes, you write up a process for a committee that oversees code development. And then if the proposal in general is accepted, then we would make a verbal kind of presentation like this on Zoom to the committee. There was a period of, excuse me, open or public comment, and then the committee makes a decision, and then you have new ICD codes. So it sounds very straightforward, right? So this was kind of the proposal process. So from December of 2021 to October of 2023, we went through kind of 2 rounds of this, of making a proposal, a presentation, public comment, and then if people can see here in my mouse, there was a decision after our initial proposal where we had to go back to the drawing board, revamp a proposal, and come back with a pared down version. So basically, most of the time when someone asks for an ICD-10 code, they ask for like 1 code. And so the fact that we were asking for 33 was kind of blowing people's minds. And so part of what we had to do was just pare it down to the absolute minimum we could get away with, but still keep the heart of our proposal request intact. So in the proposal, you put a rationale together. We put together supporting clinical data and references. And then the most complicated part is that the codes have to fit into the existing ICD-10 system. So Monica Baker really put a tremendous amount of work making sure that this made sense, both in terms of the kind of complex structure that exists for ICD-10 codes, as well as made sense kind of medically and biochemically. So when we put these codes together, we asked for guidance, which ones we asked for, got kind of the vague answer, like ask for what you want. But the truth is you have to play a little bit of, be a little bit politically savvy about this. So we had to kind of think about which ones are most prevalent, which ones are most severe, which ones had treatments or clinical trials where we could really justify it to the CDC committee. So this was a list of all the codes we asked for originally, and it's much longer than what we ended up achieving. But just to give you a sense that we weren't trying, that we really went in with a big list of requests. And so some of the examples we gave to the committee, for example, so leukodystrophy with vanishing white matter disease, caused by mutations in the EF2B 1 through 5 genes, and has a progressive course. And often, as I mentioned before, it gets misclassified or misdiagnosed as MLD or multiple sclerosis. And as many of you know, there's a clinical trial underway, and there's other clinical trials kind of in the wings as well. Alexander disease, shown here on the right, totally different disease. It has a different gene cause, and it also has a clinical trial going on, but a totally different treatment trial. And so we're trying to really illustrate to the CDC committee that, look, these are different diseases, different genes, different treatments. And here at the bottom, AGS, Aicardi-Goutieres syndrome, different set of genes. So 5 or 6 different genes that can cause it. And then now there's actually a treatment that is basically kind of standard of care, baricitinib, for people with AGS. And so that's why it's so important to have different codes for these different diseases. So great. This was the process, basically, long and complex, lots of back and forth, lots of editing to put the proposal together. And then, the short answer is that we were successful in the end. So these are the new codes that are now in place. I think that you've probably seen these in emails as well. And so there are codes for specific leukodystrophies. So for example, Alexander disease has the code G31.86, whereas vanishing white matter disease has the code G11.6. So now these diseases, which are truly distinct conditions, have their own codes. We still have left a code here at the bottom left, G31.80. And so there are diseases that we unfortunately couldn't get included in this request, and those should be coded under G31.80 unless there's a specific better code that fits them better. So this work's now been presented by Monica at the ULF this past June, and so she had a very nice poster there that you can see here. We're also happy to share it around. And then there's also a publication, which I think you can access online, where we describe the process that I'm kind of explaining today in written form, as well as talk about the new codes. And then we've had various discussions with groups, including the ULF, and other foundation groups that I see here on the call. You know, how do we get the word out to coding professionals? How do we message this to the population at large? There's a nice press release here from the University of Utah about the new codes, and with a nice patient story who's really benefited from this. And then there's more complex things about how codes get used, because as many of you may know, there's a new ICD system coming in the future, a new code system which will be adopted. These codes will be put into that new system as it opens up. So we've already kind of thought ahead to that process. This has been very focused on US, and I'm less familiar with what's happening at the international level. So those are all kind of important considerations. So I'm going to stop sharing, but if you can please hold with questions, because I want to let my colleague Garnette McLaughlin talk about codes from a coder's perspective. And so Garnette, let me turn the floor over to you. Oops. No,
You're muted. There you go.
There we go. Yes, the ever popular phrase of the last few years. You're on mute. Hi, everybody. I'm Garnette McLaughlin. I hope everybody can see my screen.
Looks good.
Fabulous. So thank you for allowing me to come today. This was an area that I had some familiarity, say that 5 times fast, with, but it was also a really great learning opportunity for me. So thank you all for providing that. So as you mentioned, I am indeed a professional coder. I wear many hats. And I'm going to give the standard disclaimer. I'm not going to give specific advice. There's a lot of variation and things out there. And so I really just want to give some general information to give people kind of a starting point for maybe what questions to ask, maybe some questions you weren't aware of, you know, areas and things to follow up on for further research. So there's my disclaimer. A little bit about me. So I moved into the health information management field longer ago than I care to consider. I moved in as an inpatient coder and sort of branched out from there into other areas of coding, and also got into clinical documentation improvement, denials management, data analysis, and software design. So that's just a little about my background. So first, I'm just going to talk about who are these mysterious medical coders and what do we do, right? So in essence, really what we're doing is, as he mentioned, was we're looking at the documentation in the medical record, and we're going to assign codes to either the diagnoses or the procedures that are there within the medical record. And we do have a lot of different rules and standards that we have to adhere to as we're going through that process. So a big part of our job is learning and knowing what those expectations are, keeping up with all of these different code updates, and being able to do our job effectively. So just a quick, scary overview of the process. We're just going to read the record. What does it say? We're going to look and see if maybe there's some documentation missing. We're going to identify anything reportable, any diagnoses or procedures. We're going to find the correct code to represent that. And then we're going to get those codes assigned and put in the correct order. And there's lots of rules around that. But I'm going to say it, and I'm sure Dr. Bonkowsky is probably like, yep, I hear this all the time. Always based on provider documentation. So what are codes used for? So I think most times when I'm talking to folks, they think about medical codes as being used primarily for reimbursement purposes. But there's really a lot of different places that these go, as we've been talking about. They go into research, which is something that we are so concerned with here. Tracking incidents, disability claims, coverage. And I know that there were questions about that. Don't worry, I've got you covered. This is the scariest thing that I will show you, and I promise I'm gonna make this go away real fast. This is the Centers for Medicare, Medicaid, and Medicare Services. Their idea of what data, where it all goes. This is insanity, right? but it's going into patient care. It is going into reimbursement. It's being used by hospitals or providers for accreditation and credentialing. It is so critical that this data that comes from these codes be correct. And I'm going to make this go away, guys, because I know that nobody loves that picture. So again, you saw that first kind of graphic did touch on research where CMS just kind of ignored it. But that is such a critical thing, and where these new codes come in, is that being able to facilitate research. So with the, every year we've got code changes that come down. They happen on a regular schedule. So for October 1st of this year, we ended up adding a total of 395 codes, which actually is not a lot in a year. And deleted 25. So all across ICD-10 diagnosis codes, that's how many changes they made this year. So Dr. Bonkowsky mentioned there wasn't a lot available prior to this rollout. And we really didn't have a great place for these. And you can tell the default code, so if a provider just says leukodystrophy without saying any additional information about it, it actually went to a different code. E75.29 is where that actually went, which we don't love. So now you can see this code set has expanded considerably. So now when I go into the code book and I'm trying to look up and say, okay, I've got a documented diagnosis here in the record of leukodystrophy. When I go and look this up in the code book, I start to see more options available. So first, if they just say leukodystrophy and no additional, I'm going to find, as you mentioned, G31.80. But then we've got all these other codes available as well. And I did, it may actually, depending on how you look at this list, it may have more codes on it, because I also went through and said, where are some of these included potentially in the same code as well? So I'm not sure, Keely, if we can make these slides available after the presentation, because this is a lot and I don't want anybody to have to write all this down. But I'll make sure that I get my slides over to Keely too.
Wonderful. I'll get them posted to our website as soon as I can.
All right, fabulous. I think one of the questions as I talked to other professional coders and worked with educating folks on the new code set for this year, I get a lot of questions. Why are some of these codes start with E and some of them start with G? This is actually really confusing for coders. So diagnosis codes are actually broken down into chapters. So those letters basically signify what chapter they're in. So those E codes are in the endocrine chapter, and those G codes are in the nervous system chapter. And so those codes are kind of put into chapters based on a combination of different things. So as Dr. Bonkowsky mentioned earlier, some of it's a little bit political savvy, trading off what makes the most sense. So there's multiple things that come together to make that decision. But it is one thing that I will say is you're looking towards driving usage of these codes, making sure that coders understand this is going to be really important, because it can be very confusing to a coder. It's like, but it impacts myelin sheath. Well, there's a little more to it. So you have some codes that are going to start with E and some codes that are going to start with G. And that's just reflecting the vast differences amongst the leukodystrophies. So driving new use of these new codes. So new codes are great only if people use them, right? So as I mentioned, coding is always based on provider documentation. So I actually back up and say, yes, we need to educate coding professionals, but we also need to make sure we're working with providers as well. If it's not documented, I can't code it. So as patients, I would advise folks, ask your provider to update their problem list. A lot of electronic health records have maybe drop-down lists, and it's going to have those old codes in there, or there's nothing there. Just ask them to update your problem list with that. Use that code and that diagnosis when you're filling out forms, whether that's electronic forms, if they give you the space to do it, or handwritten forms, go ahead and use it. Most providers, you know, how do we say this, especially with a rarer disease, are going to be grateful for that help. After the appointment, take a look at their notes. I know Dr. Bonkowsky is probably dying a little inside, but most providers do make their notes available. I don't want to endorse any particular electronic health record, but they give you some type of summary or access to the notes. Take a look, see if they're using the full diagnostic name. That's going to be the biggest key to driving these codes and getting them able to be coded. So again, education of providers to make sure they're documenting the diagnosis, coders, so they're picking up the diagnosis. And I mentioned in here our clinical documentation improvement friends. So clinical documentation improvement professionals go and help providers improve the quality of their documentation. And so that's another key group that we can make sure that we're engaging to help as well. And then targeting also some of the references that are out there. So I have a huge reference library of different books that help me assign the right codes. So targeting some of the major used references to have something included about leukodystrophy is also going to really drive the correct use of the codes. So I did put out a couple of the major organizations that would really be great partners in driving this adoption. So the Association of Clinical Documentation Integrity Specialists, they have not only larger published works, but they also have monthly publications and online publications that clinical documentation improvement professionals look at. Great place to provide some information and get the word out. Similarly, American Health and Patient Management Association, where a lot of us coders live, that's another place that's got great references that they make available, as well as monthly publications, and also the American Academy of Professional Coders. So those would be three organizations I would say, hey, let's make sure that we get them some great information that they can get out to their members to help people know how to document and assign these codes. There's a couple vendors that I would also target that produce a lot of references that are used actually in the coding and clinical documentation improvement processes. So 3M, that is a maker of a software product that embeds a lot of references, including a very nice clinical reference. We want to make sure that they have that information and can get their references updated. Optum, as much as I have mixed feelings about Optum, they also provide a lot of those reference materials for clinical documentation improvement in coders. And the American Medical Association has a number of publications that are used in particular by professional coders. So those would be three organizations that produce references that are used by a lot of these coders. And we want to make sure that we can get something in there that talks about these codes. And so Keely was kind enough to collect some pre-webinar questions, and I just wanted to touch on a few of these that really hit home for me. So the first pre-webinar question I wanted to tackle was, do you know how the codes will be incorporated into different EMR systems? Is it automatic? There's a lot of different systems out there, but typically the companies, all of these code updates happen on a schedule. They know when they're coming, and most companies are planning ahead for that. So it should already be there. If you're seeing something missing, so I'm going to assume that this is coming more from the provider side. If you're seeing things that are missing, you might need to reach out to your internal IT support to make sure that they've got the latest version of the software. All the updates are there, and that part is correct. And if that's all there and the updates are there and things still aren't right, that would be the time then to follow up with your EHR vendor. But yes, for the most part, those automatically get updated because they know what the schedule is. All right, guys, I'm going to talk about this one, the elephant in the room. I saw a lot of concerns regarding how these codes were going to be used by insurers and insurance companies, which makes me very, very sad, but also functioning a lot in denials and appeals world. I was not surprised to see these concerns, and it is something that crossed my mind as well. So I'm going to go ahead and talk about it. So first things first is even getting for the provider, getting a clean claim in to the payers. So sometimes smaller payers aren't always ready to go when these codes are ready to go. I've seen some lag time sometimes, and they'll send them back and go, oh, you've got an invalid diagnosis code on your claim. You're going to have to call them and tell them, hey, you need to update your systems and then reprocess this claim. But that's not something I think at this point they should be up and running. It would be very, very rare that I think that this would happen, but we do see this pretty much every year with those smaller payers. So there were a lot of concerns that these new codes are just going to make it easier for insurers to target any off-label use or any other treatments for leukodystrophy and use it to deny payments, deny coverage. And I share that concern because you're right. It does give them an easier point of data to identify that. That being said, as Dr. Bonkowsky mentioned, while leukodystrophies as a group are not as rare, each individual one is. And it takes resources on the part of these insurers to develop however it is that they're identifying these claims, and they may or may not think that it's going to be worth the return on investment to pay a lovely programmer to set all this up. It's really hard to predict, but I'm not ever going to be false and say that, no, that'll never happen. It is possible. It is a point of data that it becomes very simple for them to identify. So that being said, what I would urge folks to know is that both providers and patients have the right to appeal. If you, as a patient, get a letter that a coverage denial happens, make sure that you understand what that letter's saying, and see if there is, and there should be, a defined appeal or dispute. Sometimes they'll call it grievance. I use different terminology, but there should be a defined process to appeal that denial of coverage. And usually you do have to go through their process before you go out to any type of external review or complaint. So what do I mean when I say external review or complaint? So health insurers are actually regulated on the state level for the most part. And usually it's some kind of state department that says something like Department of Insurance, Insurance Department, something of that nature. And I did put a link here that will take you out to a place where you can actually look that up. And a lot of them, you're going to look for something along the lines of how to file a complaint, how do I file for an additional external review. You want to look for some type of a position like an ombudsman is usually what I've seen that called. But those are people that are positioned within these departments to help patients navigate these complex disputes. But I think we all know that insurers are looking after their bottom line, and sometimes you're going to have to sort of take it outside of their opinion and go to some of these external resources, which can be very tough and very, very tiring. And there is help out there to do that. So one place that I would recommend, if you are really running into just some egregious behavior, it's been very hard, very difficult to resolve, there actually is now an Association for Healthcare Denial and Appeal Management that really is trying to fight back against some of these tactics that I think some of you have experienced. So that's another resource to reach out to help, whether it's understanding the process, understanding rights. How do you write this? Most of these are written appeals. How do I write this in a way that's gonna get us the win, right? That's what we want. So at the end of the day, yes, we want people to use these codes because the positive benefits are so enormous, but there are some challenges around that I think some of you are aware of and that identified, but there are ways to fight back against that if you do encounter that. So those are a few of the pre-webinar questions that I was just going to go ahead and just hop right on. With that, I'm going to come up for air. That was a lot to take in, and open the floor up.
Garnette, that was great. Keely, do you want to help run any questions or stuff that have come up?
Absolutely. First off, thank you so much for that, Garnette. That was amazing information, as well as your presentation, Dr. Bonkowsky. I would like to open up questions. So we do have one in the chat. If you would prefer to vocalize your question and be on camera rather than type it, that is absolutely okay. Just go ahead and use the raise your hand feature in Zoom. That'll help me pinpoint who has questions. But first, I'd like to start with one that was in the chat. It says G23.3 says HABC, but will this also, oh my gosh, I wish I could read today. I'm sorry, let me start over. G23.3 says HABC, but will this also be used for all TUB4A related leukodystrophies? Dr. Bonkowsky, would you be able to cover that question?
I can try, and then Garnett, you can correct me. I think that it will not cover all TUB4 related conditions, because we specifically wrote it not to, because some TUB4 related diseases can be like dystonia also, so a completely different kind of set of symptoms. And so we were careful when we put the code together just to relate it to that description of disease. So it's in one way it's a little bit limiting because it's defined to the HABC type symptoms, but on the other hand, we were worried that it could kind of get confusing, as we just explained.
Okay. Yeah, and my read on things, it would be the same. I think what gets really challenging as a coder when you lack familiarity with a condition, and there's not maybe a lot of clear coding guidance on how that should be classified. There's my fancy term for it. It gets really tough, and you get really scared of, am I going to assign the right or the wrong code for this? And I don't think people would assign that G23.3 based on the information that's out right now.
Okay, Melody with Cure LBSL, you have your hand raised if you'd like to go ahead and unmute.
Hi, thank you so much. This was amazing. I have a question about E8843, which is where LBSL, we believe, will be falling into, but it's a more broad category, and I believe several of the, or all of the ARS disorders will fall under that. And so my question is, how do the coders know where to put LBSL? If you go to the CDC's lookup tool and you type in leukodystrophy or LBSL, or spell out LBSL, which is leukoencephalopathy with brainstem and spinal cord involvement and lactate elevation, a really long name, none of those pop up on the tool. And so, like, how would a coder even know to type in tRNA synthetase to find the right code without being told? And is there any way that we can, as a patient advocacy group, is there any way we can help that process?
Yeah, I'm just pulling that up. Leukoencephalopathy, I'm just trying to think here. I'm actually in my code book looking as you're saying, because I'm putting my coder hat on and saying, okay, now if I ran across that, what would I do? And you're right. I think that you'd really have trouble figuring out which code to assign. So this one, I think, would be one where trying to get education out to like the clinical documentation improvement folks and coders is going to be really critical, because it's building that awareness of what are these various leukodystrophies. Coders are by nature researchers, but they're going to be careful where they get their information. So I would say, yes, this would be one where right now, yeah, I don't think the right code is going to be assigned. That's just my personal opinion.
Yeah.
But yeah, that's definitely something where getting into the education and the references that coders use on a day in, day out basis is going to be really, really critical.
That's so helpful. And thank you so much for validating that we were, our concern was real. I was like, how are they going to find this? But also that list of references that you gave us gives us a really great point to start. And so I really appreciate you. Thank you.
And we can have an additional conversation offline. I've been known to write for these publications as well. So we can have additional conversation about that.
I'd be so grateful for that. Thank you so much.
Absolutely, absolutely.
Thanks, Melody. Dean, it looks like you have your hand up next. If you would like to unmute and ask your question.
Yes, good morning. Thanks, Josh and Monica. Good work, hard work, long work. A lot of details and moving parts there. And Garnett, the perspective that you've brought, I think, is valuable as well. Just more an observation than a specific question. And I was one of those ones with some of the pre-set questions. We need to be just aware of, as we're talking to our communities, or at least this is how we're approaching our community, that families are in all different stages. Some have access potentially to some of these therapies, some don't. So they're doing clinical care, and so they need to be coded from a practical perspective. They need to be coded to access the best clinical care. My daughter, monochromatic leukodystrophy, she's got an epilepsy code because that's how she gets best seizure care. She has an MLD code as well, but she's got, I don't know, a dozen codes or something. I looked at them one time a long time ago. But it just depends on what the care is. So be careful when you're telling families that, oh, no, you got to have the disease code. Well, they also need to have code to get the access and reimbursement to improve quality or optimize quality of life. The second thing is, and this may be an ICD-11 thing. I don't know much about where we're headed. This ICD, as you can tell, has been around a while and has evolved. But from a research perspective, I love tagging MLD, but I would so much more love to tag the subtypes of MLD because we have things that are on label for certain subtypes, or we expect to be on label, and some forms of the disease that won't. So subtypes aren't generally covered as well. So this is an evolving situation. We've made big strides here, but just keep in mind that it's kind of like, getting sequencing. Sequencing is just the start. Now we got all these other buses and other stuff we have to figure out. It's complicated. So good work. Let's keep at it. Appreciate it.
All right.
Absolutely. Thank you so much for saying that. Yeah, I remember I actually watched the presentation Dr. Bonkowsky gave to the ICD-10 committee. Those are open out there for us. So I do remember that presentation vividly because it was so informative. And again, the whole community coming together from a provider side, a patient side, right? That's really what we want to see. That's what needs to happen. And as you're talking about, again, quality of life. So I just wanted to jump in on that ICD-11 question. So that coordination committee has already had some preliminary discussions about it, does not want to drag their feet on adopting ICD-11 like the United States did with ICD-10. I have actually done some of the beta work for WHO on ICD-11, and you're right, there's a lot of development possibilities in the subtypes of leukodystrophies there. They've actually started and added some of that in the latest release, but yeah, more work is definitely needed there. And you're right, it's going to be nice to be able to get down into subtypes. So it's when my MS waves high right now in the United States, all they can know about me is that I have multiple sclerosis. They don't know if I have primary progressive, secondary, and it tells them nothing about what my course is, may be, and how aggressive that needs to be addressed. And this is no different. So yeah, looking forward to ICD-11 for that.
Yeah, and I wanted to mention one other practical thing. I'm about being pragmatic. When you're going back to your doctor and you're saying, please make sure this new code is attached to my loved one, the right doctor, I'm sure any doctor could do this, or any staff behind the doctor could do this, but probably the place you'll have the most success will be the specialist. Don't go to the PT person and ask them to do a disease code. They're dealing with other stuff, but go to your, in my case, a neurologist or whatever it may be that's a specialist for your disorder. They'll know how to do that. And their coders probably will be more familiar with these details as well.
Yeah, and as you mentioned, you can have multiple codes for one condition. I won't go too crazy in coding land, but basically there's a rule in coding that says if a symptom of a diagnosis is inherent, it happens all the time with that diagnosis, you don't report it. So like, for example, somebody has pneumonia and they have a cough, you're not going to code that they had a cough. But the opposite is also true. If somebody has a diagnosis, and that's not how basically 95% of the people with that diagnosis present, you code that as well. So yes, you absolutely want to make sure that any of those additional symptoms that aren't typical are reported too. So, and that your provider's documenting them. But that comes back to, like we talked about, some of the education. I think as a coder, this would be something that we'd be going, I don't even know what that is, let alone what is normal presentation for that. So that's where the educational components really going to be critical.
Wonderful. Thank you. We do have a couple of more questions in the chat that I will get to right now, but if you are watching, again, feel free to use the raise hand feature if you would like to ask your question on video or on audio, or go ahead and put your questions into the chat. So like I said, we've got two on deck. The first question is, do you know how these may be applicable abroad and potentially in the UK?
So we're special snowflakes in the US. So backing up, ICD-10 is put out by WHO? And it's just literally ICD-10. But we're special in the US, and we take it and we do what we call a clinical modification to it. So these are US specific codes. So things in the, I don't know off the top of my head if the UK does their own. There are other countries that do their own modification. And I don't know if the UK does as well, but yes, this would be specific to the United States.
Okay. The next question, so on the ULF website and in our press release and University of Utah Health story, it does say that the TUB4A related leukodystrophy, and then in parentheses, HABC. So kind of circling back to that previous HABC question, perhaps there was some adjustments when the codes truly rolled out on October 1st. Maybe there was some clarification there with that code being specific for HABC and not necessarily TUB4A related leukodystrophies?
I think when I put together my,
No, go ahead.
When I put together my list, I went through the book and literally pulled out how it was published to coders in the book. So under that G23.3, it includes HABC specifically.
Okay. Okay, so to circle back to their original question, though, just to clarify, you know, will it also be used for all TUB4A related leukodystrophies? Was it just a simple, you know, by the time it made it to the hands of the coders, there was just a slight adjustment there?
I think so. I'd have to look back at the pathway of it, but yeah, I mean, right now as a coder, it would not be clear.
Gotcha. Okay, well, that's great for us to know, and we will make a note of that on in our press release. And as we continue to share information about the ICD-10 codes, it's a great question. Thank you to those of you in the chat that were asking that question for that clarification. Obviously, it's very important for us to have a clear understanding of these codes and how they can be used. And, you know, but at the same time, we can share a whole bunch of information. And then when the actual book gets printed, we only have so much control. So it's important for us to be able to pivot and make sure that we're sharing accurate information as we go. So we are certainly learning, and, you know, as we move along in this, the codes are very new. Things will change slightly, you know, as they get into use. You know, just the world is a very variable place, and as we put things into practice, things will adjust as they go. So we will continue to try to keep the most up-to-date information as possible available to all of our community. Last call for questions. If you would like to raise your hand or put it into the chat. Otherwise, I would like to just take one moment more to say thank you again to Dr. Bonkowsky and to Monica for all of her amazing work on getting these ICD-10 codes. We have a question in the chat. Imran, because that is a more general question for leukodystrophies in general, I'm going to copy down your question and I will respond to you via email that you provided when you registered. Again, thank you so much to Dr. Bonkowsky and Monica for all their amazing work on getting these codes put together and implemented. Such a huge advancement for our community. Melody, did you have a question? Or, sorry.
No. While I had clinicians on the group, I'm kind of speaking for the GLIA patient advocacy groups. The individual groups are taking the lead on their own communities, and so some people are doing t-shirts and some people are doing sticky notes and trying to get our patients and families and clinicians to remember to share the codes at each visit. But I was going to ask, as we have clinicians on the line, what would be the most impactful way that the groups could reach you? Like, would you like a mouse pad? Would you like a mug? Like, what way is impactful? What have you enjoyed in the past? Or for coders, for Garnette, if LBSL sent you something like, hey, remember E8843? What would you like?
Is it stress ball?
Stress ball. We can do that. I bet Monica could use a stress ball right now too. So.
You have one of those giant pencils, with all the codes on it,
Remember.
That's funny. But yeah,
a pencil that you can roll, that has a sleeve of paper wrapped around it that you can roll it out, and
that's hilarious. I love that. Those things do exist, I'm sure, right?
Well, and if your catchphrase is sort of like remember the code,
yeah,
a notepad with that at the top.
Perfect. Thank you.
Write it down.
Amazing. Thank you, Melody. All right, and I will bring our session to a close. If there are any additional questions, or if you're watching the replay of this video on YouTube, please feel free, if you have any questions that have popped up from this session, shoot them on over to office@ulf.org, office.org, at ulf.org. And I will get those questions directed to the proper individuals, and we will get you an answer. Thank you, everyone. Thank you, Dr. Bonkowsky and Monica, for all of your work. Thank you for being with us today, Garnette. You have been a true wealth of information. We so appreciate having everyone on the call here today. And yay, go leukodystrophy community for this amazing accomplishment. Thank you, everyone, and I hope everyone has a wonderful rest of their day. Thank you.
Thanks, Keely. Thanks, everybody. Good to see you all.
Thanks, everybody.
Thank you.